Good morning friends, welcome to my channel Medics Tutorial. Today's this is the second video of the urinary system. Today's topic is embryology of the urinary system. Urinary system get derived from the intermediate mesoderm. To understand the intermediate mesoderm, we we should look this. This is the egg and this is the sperm. They get fused and the fertilization takes place. after after 2 or 3 weeks gestation takes place. What is gestation? Gestation is simply formation of three germ layers. This is the ectoderm, mesoderm and endoderm. So from mesoderm there are again three layers from this. These are the first one is the paraxial mesoderm, second is intermediate mesoderm, and the third one is the lateral plate mesoderm. So remember this intermediate mesoderm which gives rise to the urinary system and the reproductive system. There are three stages of the urinary system development as follows. First one is the pronephros, which develop at the 4th week of development, which get degenerated at the end of the 4th week, and it is non-functional as well. Second stage is the pronephros, which develop at the end of the week 4, which function as the interim kidneys for the first trimester. Interim kidneys means it works as a temporary kidney until the permanent kidney take over it. It gets degenerate in the females and it persists in a male genital system as Wolffian duct, which form in the ductus deferens and epididymis. Will see it in a reproductive videos. Third and the most important stage is the metanephros, from which the permanent kidney get developed. It appears firstly at week 5 of development. From week 5 to week 36, permanent kidney is developing. Also, we can say that nephrogenesis is normally completed by week 36 of gestation. As you can see in this diagram, the pronephros is already get regenerate. mesonephros and the metanephros. Mesonephros have mesonephric duct, and the metanephros have the metanephric mesenchyme and the uretary bud. As we can see here, the uretary bud get arising from the caudal end of the mesonephric duct, as you can see in this diagram. Uretary bud or the metanephric diverticulum derive from the caudal end of the mesonephric duct, which gives rise to ureter, calyces, collecting duct, which fully canalized by the week 10 of development. Now, metanephric mesenchyme or the metanephric blastema. Uretary bud interacts with the metanephric mesenchyme. This interaction induces differentiation and the formation of the glomerulus through the distal coronary tubule. So, to understand this, we should understand this first. Urinary system have two components. That is, the first one is the excretory system or the excretory component. Second one is the collecting system or the collecting components. From in excretory there are components like the Bowman's capsule, glomerulus, proximal coronary tubule, loop of Henle, and the distal coronary tubule. So these forming the excretory system, which are get derived from the metanephric mesenchyme. Simple. In urinary system had two components like the excretory system. The components of the excretory system are the Bowman's capsule, glomerulus, proximal coronary tubule, loop of Henle, and the collecting duct, which are get derived from the metanephric mesenchyma. That's it. Now second one, that's a collecting duct or the collecting system of the urinary system. These have components like the ureter, pelvis, calyxes major and minor, and the collecting duct. These are get derived from the uretary bud. So it's very simple. Get it? Aberrant interaction between these two tissues, mm, that is a uretary bud and a metanephric mesenchyme, may result in several congenital malformations of the kidneys. Example: renal agenesis, multicystic dysplastic kidney. We'll see it in upcoming slides. Ureteropelvic junction. It is the junction between the renal pelvis and the ureter. This is the renal pelvis and this is the ureter. So this is the ureteropelvic junction. It can be a unilateral and a bilateral. So this is the unilateral and this one is the bilateral. This is the bilateral. Most common pathology. It is the most common pathology cause of the prenatal hydronephrosis, and it is detected by the prenatal ultrasound. Embryological defects of the urinary system: pottersequence, horseshoe kidney, congenital solitary functioning kidney, unilateral renal agenesis, multicystic dysplastic kidney, duplex collecting system, posteriorurethralvalves, and the last vesicoureteralreflex. We'll see all these defects one by one in next slides. First one is the pottersequence. Let's see the pathophysiology of the pottersequence. Oligohydramnios. It's a very main trigger for the pottersequence, which means the low volume of the amniotic fluid in the placenta, which leads to compression of the developing fetus, which again leads to the limb deformities, facial anomalies, like low set ears, retrognathia. Retrognathia is the unusual position of the mandible, as you can see in this image, flattened nose, and the compression of the chest and lack of amniotic fluid aspiration into the fetal lung, which eventually leads to the pulmonary hypoplasia, which means the incomplete development of the pulmonary lung tissue, which causes death. Pottersequence caused by the chronic placental insufficiency, reduced renal output, including the autosomal recessive polycystic kidney disease, obstructive uropathy, and bilateral renal agenesis. It is said that babies who can't pee in uterine life, they can develop pottersequence. Pottersequence Potter itself is a mnemonic for the criteria associated with the pottersequence, like P for pulmonary hypoplasia, O for oligohydramnios, which is the very important trigger for the pottersequence. T for the twisted face. Second T is for the twisted skin. E for extremity defects, and R for the renal failure in utero. That's all about the pottersequence. Horseshoe kidneys. Horseshoe kidney means it's appearing like a horseshoe shape. That's why it's known as horseshoe kidney. Let's see the pathophysiology of it. Inferior poles of the both kidneys fuse abnormally, as you can see in this diagram. These are the inferior poles of the kidneys, and it get fused, and it's appearing like a horseshoe shape. That's why it's known as the horseshoe kidney. As they ascend from pelvis during fetal development. Horseshoe kidneys get trapped under inferior mesenteric artery and remain low in abdomen. At the time of development, kidneys firstly get developed in pelvis, and at, after get developed, it have to ascend upper abdomen. But in case of horseshoe, it get trapped under inferior mesenteric artery and remain low in abdomen, as you can see here. In case of as compared to normal kidneys, horseshoe kidneys present lower in the abdomen. Uh, kid, Kidneys can function normally, but associated with a hydronephrosis. Associated with a hydronephrosis. Associated with a hydronephrosis. Example: uteropelvic junction, renal stones, infection, in increased risk of the renal cancer. Mm, in horseshoe kidneys is higher incidence in chromosomal aneuploidies like Turner syndromes, trisomies. In such patients, in horseshoe kidneys is most likely seen. Congenital solitary functioning kidney. Uh, it is condition. It is condition being born. It is condition being born with only one functioning kidney. Although patient have both kidneys, but the only one kidney is functioning and one kidney is not functioning. Majority of patients are asymptomatic because of the compensatory response from the functioning kidney. Functioning contralateral kidneys, but anomalies in contralateral kidneys are common. Uh, it is most often most often diagnosed prenatally via the ultrasound. Unilateral renal agenesis. Pathophysiology of the unilateral renal agenesis is just because ureteric bud fails to develop and induce differentiation of the metanephric mesenchyme, so it leads to the complete absence of the kidneys and the ureter. So there will be only one kidney and ureter will be present in a patient. Multicystic dysplastic kidney. Let's see the pathophysiology of it. Ureteric bud develops but fails to induce differentiation of the metanephric mesenchyme, which leads to the non-functional kidneys, which consisting of cyst and connective tissues. Predominantly, predominantly multicystic dysplastic kidneys are non-hereditary and usually unilateral. If it's bilateral, then it leads to the pottersequence. Duplex collecting system. As this is a duplex collecting system, we can see that there will be definitely problem with the uretary bud, as the collecting system derived from the uretary bud. So let's see its pathophysiology. Bifurcation of the ureteric bud before enters the metanephric blastema. It creates a Y-shaped bifidurator. Let's see what does it mean. So this is the metanephric blastema. This is the metanephric blastema, and this is the ureteric bud. This is the ureteric bud, and it get bifurcate and forming the Y-shaped bifidurator. So there will be there are two ureteric, it get formed two ureteric buds, so it will lead to duplex collecting system. Duplex collecting system alternately occurs through two uretary buds reaching and interacting with metanephroplastomia, strongly associated with the vesicoureteral reflux and or the ureteral obstruction increase the risk of the UTIs. Frequently present with the hydronephrosis, obviously it will accumulate the urine in kidney. Posterioruretral valves. um, instead of going to the theoretical part, we'll see the difference between the normal and the posterior urethral walls, as we can see in this image. So on the left hand side, there is a normal urinary system. On the left hand side, there is a defective urinary system. So in left hand side, there is a normal kidneys, normal ureter, normal bladder, and the normal urethra. So the urine get passed easily. And on the right hand side, there is a problem with the posterior wall, the posterior urethral wall. So the urine is not getting passed easily. We can that's why we'll see some changes in here, like the hypertrophied bladder wall, distended walls as the urine get accumulate. That's why the bladder get distended, and the urine due to the accumulation of the urine bladder, the urine getting a reflux in the ureter and the kidneys. So that's why the ureter get hydroureter and the kidneys are hydronephrosis. That's the accumulation of the urine in kidneys and the ureter. So if so the membrane remnant in posterior, that is prostatic urethra in male especially, its persist can lead to the urethral obstruction. Diagnosed it get diagnosed prenatally it get diagnosed prenatally it can be diagnosed prenatally by by you by bilateral hydronephrosis, dilated or the thick walled bladder on the ultrasound. Severe obstruction in fetus associated with oligohydramnios, and it most commonly cause bladder outlet obstruction in male infants. Vesicoureteral reflex. So retrograde flow of urine from bladder toward upper respiratory tract means the backflow of the urine from bladder to the urine and kidney. It can be primarily due to the abnormal insufficient insertion of the ureter within the vesicular valve, that is at the ureterovesicular junction. It is the junction between the ureter and the bladder where it get inserted. Secondarily, due to the abnormal high bladder pressure resulting in retrograde flow via the ureterovesicular junction, and it leads to the increased risk of the recurrent UTIs as the urine getting backflow in the upper respiratory tract. Here we're done with the embryology and embryological defects of the urinary system. Next, we'll meet in next video with the anatomy of the urinary system. Thanks for watching. Like, share, and subscribe.